I'm going to, I'm ahead of the game now, I see. We're going to go over, neuro.
We're not doing research yet.
They don't take recess. We'll go play on the phone.
Okay, I'll start again. I'm ahead of the game. So all I have left is some peripheral neural disorders.
Oh, wait, one more thing. I posted some study guides for all the stuff that she talked about. So and there are no answers, so don't ask me. CDA, neuro, some vision stuff, and if I can go find some ear stuff, I'll post that in Blackboard too. It's in your assignments tab, and that's going to help you study.
Okay, so I said that I'm ahead of the game for peripheral disorders on Tuesday. What I'm going to go over is a few spinal cord injury nursing interventions the nursing needs to know today. And then, do you mind if I begin the concept blending today? Do you mind? Okay. That way you'll have that much, and then we'll do concept blending on the rest of the information I present on Tuesday. We'll be ahead of the game, and then I still will meet with you guys on Wednesday for those who want to come. And those who come, and the others are in clinical, take it for me.
Yeah, I'm going to be here to go over the neurological concept blending.
Well, go ahead and do it all.
Because then we come Tuesday, we just do concept.
But people have to come to class.
Oh, that's fine.
Depends on how much sleep I get.
Right.
Thursday, you don't have any, you're done with your skills on Thursday.
You just gave me wrong information. I know. I have to. I'm going to put that in place.
Let's take a vote. Do you want to go and get all this information done today? No. Two questions. You want me to finish up with spinal cord, which is part of what I was going to present today?
No, we want to go for
The two choices are, I'll end with spinal cord and do a concept blending today on what we've covered so far, or I'll finish up the peripheral nervous system disorders and I will do a complete concept blending on
Finish up.
Option 2.
Yeah, option 2.
Yeah,
Okay.
We'll forget it.
Okay, so I'll go ahead then. Yeah, let's go ahead.
Yeah.
Okay, spinal cord injury. What gender and what activities would you expect to be highest risk for acquiring spinal cord injury?
Males.
Huh? What age group? Young men.
Young adults.
Teens to young adults?
Where's the data? Is it not
No, I'm just, because there's only 3 questions, that's one. So
Oh.
I'm just telling you, and these are the things to know. Those activities, bungee jumping, risk taking, the NBAs, as a result of alcohol ingestion with it, predisposes predominantly young men, teens through young adults for having spinal cord injury. What's she do?
What do white people?
You want some notebook paper? I'm okay. You sure? Yeah. Thank you.
You are white, Renee. So you know, honey, you just don't know.
19 years in life.
Okay. All right. Moving on. Spinal cord injuries. The higher the injury to the spinal cord, the more dysfunction below. What that means in your book, level C4, cervical 4, I think it's C4, between C3 and C4, that affects the respiratory and the dysfunction below that. When you have a area of like lumbar sacral area injury, that affects your elimination. And of course, The person can have paresthesia or paralysis, predominantly paralysis. Okay. So that being said, again, the higher the injury on the spinal column, the more debilitating the function the person has below that area of injury. It can be a partial severance or cutting of the spinal cord, partial severance of the spinal cord, or total severance. If it's total severance, they're not going to get that nerve innervation below that injury at all. Partial severance, there may be unilateral functioning. Sometimes it's not even a severance of the spinal cord. It may be the inflammatory response. Edema sets in and constricts the spinal cord. That being said, medication of choice, if inflammation sets in, is one of your corticosteroids. And the one you need to remember for test purposes, IV route is Solu-Medrol. Solu-Medrol. Solu-Medrol is the corticosteroid used to decrease the inflammation for any injury relative to spinal cord injury. There are times when you give the Solu-Medrol that the person, if there isn't a severance, the function below the level of the injury comes back. Of course, with rehab, physical therapy, occupational therapy. You as a nurse are responsible to promote the function of the patient depending on what is the dysfunction secondary to the injury. That being said, if this is a C3 or C4 injury, and you don't know that yet, let's say it's an MVA, and you are the first nursing personnel that comes on the scene. And what is that little, it protects you from intervening. Huh? The Samaritan law. If you suspect that there is a neck injury, how would you proceed in moving that patient?
You wouldn't.
You don't. Unless what?
Cars on.
Fire or they're in harm's way. How would you move them?
C-spine.
Let's say you ain't got that.
C-spine.
C-spine. You want to, you do not have a trusted little cervical collar. You want to immobilize the head. That being said, I want somebody, I want two guys. Jamie, do you mind being the patient? I want Rob, do you mind being the nurse?
Sure.
Okay, and Jason. I want Jamie to come here. And you guys are first on the scene. Y'all are coming from nursing school. And you notice there's this MBA. And you notice her just on the side out of her car. And you notice that there's been some impact. And you notice gas leaking out of the back of the car. She's in harm's way, isn't she? Okay. So, Jamie, I want you to be down by your car. And you guys can stand up if you need to. They notice that one of her legs is to the side and her neck. Okay. Now, they come on her. What do they do first?
Are you
Are you
okay?
okay?
Okay.
Yeah, I got it wrong too.
Okay. Now, you notice she isn't moving any of the limbs. Okay. Simple ABCs. What do you need to be looking for? And you want to know if her chest rises. Okay. Her chest is rising. She's breathing. So you know it's not If she did have injury, it's probably not what? C3 or C4. So she can breathe. But you still need to maintain her in alignment. So I want you guys to demonstrate log rolling and lifting her like if you were going to lift her to a table. Okay. So you know you have a cervical collar. You know that you got to protect her limbs. But mainly here, show me how you would immobilize her head.
Just like a white bird.
Hold her head.
In alignment, okay.
Are
And
we
then
rolling her onto
we need
something?
another person here, Damien. Okay, because Jason's gonna keep her limbs so they're not dangling, and Damien's gonna have the middle. I want you guys to properly log roll her and lift her.
So
Okay, you need a spokesperson to say on the count or whatever, we're going to roll her here and we're gonna lift her. Okay, who's the spokesperson? Okay,
sorry, on three we'll roll her.
Wait to the other.
1, 2, 3.
okay, good. Now, how are you gonna lift her?
Slowly.
Okay. It's not as easy as you think.
1, 2, 3.
Oh.
You guys did it right.
It's a
All right.
That was awesome.
All right. And you did her head that way so you wouldn't have any twisting because even though she can breathe and everything, you don't want any twisting of that cord. Okay. So they're going to take this person to the hospital. And they're going to be on a backboard. They're going to log roll her on a backboard. She's going to have a cervical collar. They're going to do all the lab work. CBC, CNP, all of that. They're going to immediately get her ready for x-rays. Okay, while she's on that backboard. The ER will not remove the cervical collar or any immobilization till there's determined the level of the injury and the extent of the injury. And they won't, if there's injury, they're going to leave it on until she's transferred out. Any spinal cord injury does not stay local. We are not that level of neuro here. First medication, you know that they're going to give, when it's an injury and inflammation set in, is Solumedrol, IV push. You want an IV going not only for the Solumedrol, but you want to hydrate this person. You don't know how long she's been out there. Okay. They're going to do an EKG. Along with all the x-rays, of course, a chest x-ray. Also, a Foley catheter will be put in because you don't want this person moving. If she has some injury and she has some degree of pain, you need to have all your evals done, and then it would be the neurologist who would determine what med and what degree. You want to do all your evaluations first. That means ER doc, referral to neurologist, so all the assessment is done. It's done quickly, so this person's out of your facility within an hour. Some people are taken right from the scene. They're lifted, they're gone to a neurocenter. She's in the car by herself. She's talking. What's important for you, well, before EMS gets there? What would Rob, Damien, and Jason ask her? What are some pertinent things they would ask her so they can tell EMS? Allergies. Okay, before that.
What happened?
Family is there. You might ask her, who is she?
Who are we gonna call?
Does she know where she's at?
Do you know where you're at? All that neuro stuff. Do you know where you're at? Do you know what day it is? Who's your family? Are you local? Local. L-O-C-A-L. Not local. 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 Okay. If she is, you know, you will have that information for EMS to get. If she tells you, can you call this person for me? You do that. But if she does not give you permission to call anybody, you're not the one who should be calling. You might say, do you have family here? Yes, I do.
This is like one of my big projects, I suppose. There's a lot. Keep your driver's license and your registrations current where you live. I cannot tell you how many times we've had rollover accidents and someone has died, and it's taken us 6 hours to find who these people are. So that's like my project for everybody. I try to get that out. It's horrible trying to call these people and figure out and knocking on doors at 3 in the morning and no, it's the wrong house.
And you know the thing about it is, reason why you want her to give consent if she can is because she can say to you, I didn't give consent, so you broke the HIPAA. But if she says to you, will you call, I just had a fight with my boyfriend, I got in this right there. Don't call him, call my mom. Okay? If she says call that person, you call that person. Yes.
What if she's not down?
She can't, you just wait till the MS gets there.
What if she tells you to call someone, but after everything she forgot that she told you to call?
You write that down. You write that down right then and there. You got 2 witnesses.
Well, if you have somebody's phone number, obviously.
Yeah. The main thing is, even though you're being heroic and doing the best you can, you don't want to break the HIPAA.
So, are we held to HIPAA for Good Samaritan?
No, no.
Okay.
The thing is,
If
but
this was we were
if she
actually
remembers that if she tells you, I don't want you to notify such and such, let her get in emergency services. The hospital will then follow.
So if we were on the clock, then yes. But
Yes.
if we're just going, found her side of a road, then like HIPAA wouldn't necessarily be like.
Strenuous on you,
Yeah.
but still, keep in mind,
Yeah.
you only need to know what you need to know.
Yeah.
She says, call so-and-so, you call her. She's giving permission. And you guys, I would say with some happy things going on these days, I would get all 3 of your signatures. That, hey, you were there. That's happening. Okay, so this person is either airlifted from the site or they come to the hospital and they're going to do all those things, IV, Tyumedrol, and the pain management will not be done until a thorough assessment is done by all involved, especially neuro. And they do it quickly if they're taken to a local hospital and they're airlifted. No, indeed, not an ambulance, they're airlifted to a neuro center. Here again, rehab is geared on what the dysfunction that person has. If they came upon her and she was not breathing, you'd stick. What would you do if she's not breathing and you're keeping the head immobile? What do you remember about CPR? How can you open the airway?
No, for head.
Drop it up.
Drop the top.
Not good. So yeah, it's weird, but it's jaw thrust. You want to open up that airway, get that tongue out of it. It's not this. Because what could you have done? Cause further damage to that spine. Okay, now this person's going to go through the rehab of physical therapy, occupational therapy. If they are on a vent, that's C3, C4, which affects your respiratory systems. They will be on a vent. They will eventually possibly wean that person off, or if that person can't be weaned, they're on a vent. There's some people that have been on a vent for a long time. Who was that? Was it Superman? Who was that guy?
Christopher Reeve.
Was it? I don't
Yeah,
know if it
Superman.
was a spinal cord injury, was it?
Mhm.
Yeah.
Okay, and he was on a vent for the longest. He died though, didn't he?
Well, not
All right.
very.
And here's another thing too. With spinal cord injury patients, you know what you do if it's a respiratory ailment. If it's lumbar, what do you think you would need to promote? If they're gone through rehab and you get them in a skilled facility or you're the home health nurse taking care of this patient, what might you need to promote elimination of?
Bowel and bladder.
Oh.
If they have a neurogenic bladder or bowel, if it's bowel, you still need to promote those dietary needs. Roughage, if possible. You want to hydrate. You still want to do, if it's possible, range of motion. Even though they can't actively do it, you can do some range of motion for their tolerance. If the person, that's for limbs and bowel. Bowel also, you will use those medications that will help them. Stool softeners, maybe some Melamag if need be, if it's progressed and the stool softener not working. And also, if they don't have nerve innervation to the muscles needed for bowel elimination, you may have to do rectal massage. Yes, you will have to do rectal massage to help the passage of stool. Have I done it? Yes. Did I like it? No. To help the patient. Okay. Bladder. Yeah, bladder. Huh? I know you. Yeah. No. Okay. Then bladder. These are the people, and Ramsey came up after class, after at the break and said, "Don't you want to put in a regular catheter and leave it in?" This is someone who's gone home. A catheter in all that time is going to increase the bacteria, but he makes a good point. If you're doing these intermittent caps, aren't they doing the same thing? Straight catheter. Yes, but then you want to promote the autonomy and, people just feel like, I don't want to go around with the catheter all the time. If it's admissible for that physician may order it. It's a conversation between the physician and the patient. Is it predisposing them to bacteria? Yes. But yet and still, you want to know what you're doing that promotes that psychological integrity of that patient. And now they pay. There's your Medicare and different people, providers pay for catheterization supplies. How would you know someone needed bladder decompression? Distension. They may have some overflow where they're just leaking. But you need to have that person relieve them of urine, and you need to have them bowel evacuated, because there's a condition they can have, and I'll say it to you. Dysreflexia. DYS. Reflexia. DYSREFLEXIA. Dysreflexia. It's autonomic dysreflexia. You do not empty that bowel or bladder, or if they have a catheter and they're laying on the catheter, it causes a sensation to the patient of pressure. Pressure with the catheter on certain dermatomes, pressure with the bowel being full or bladder being full against certain dermatomes, and that person can go into autonomic dysreflexia. What will happen? The blood pressure will shoot sky high for that person. Elevation of the blood pressure. Along with that person, if blood pressure goes up, it can affect certain neurons where they can just be spasming. Even though they have the paralysis, they can have spasm. So what you want to do is the prevention of dysreflexia is keep the bowel patent by making sure the patient is evacuating their bowel, or you're assisting them with rectal massage so they can evacuate the bowel. You want them to do intermittent cath, or you want them indwelling catheter, per what the physician is ordering. Other things that can cause them to go into dysreflexia is certain activities that we do I better put it this way, that people normally do each day. People who have a spinal cord injury still have sexual relations. So sometimes people can go into dysreflexia as they're engaging in that activity. You're not going to be there as a nurse, I would hope not. You need to let them know that certain activities can throw them into that, just due to the stimulus. Okay? So it's a medical emergency because they go into hypertensive crisis. You need to remember dysreflexia. What are some perpetrators? Usually bowel and bladder. Why is it a problem? They go into hypertensive crisis. So you need to teach that to the patient. Also, as a nurse, there's other things you need to watch for. Any skin breakdown, because they can't sense when they're having pressure along bony conduits. There are some paraplegics where that they don't have much sensation below the waist, that they get around quite well. The motorized chairs, because they have the upper arm strength, it only affected below the waist, the area of injury, and so they get along well. If you're the home health nurse and you say, well, they have paraplegia, I'm going in and I'm doing care, I'm teaching them about cat care, whatever. Be informed that even though they can have reflexes, and they will, and I'm telling you this because a lot of people think that they can't have sexual activity, they can't perform, they can't do this. They can. And you need to alert them to the fact because depression can set in, psychological separation of that person. They can live healthy lives, but they have to be dedicated. So, what was that medication we're going to give to this person?
Tell you my drill.
What do you need to promote about skin? Assess it. Have them teach them to assist with the turning, changing their position.
I guess for
how would you promote dietary or bowel and then urinary? Let's go urinary.
fluids.
Fluids. Okay, just increase fluids. What would you do, bowel? You would have fiber diet, modified to fiber diet. You would increase fluids. You would, if they're doing intermittent cath, let them know that if they're on their own doing that and they're progressing, they can pretty much tell every 2 hours they need 2 to 3 hours they need to self-cath. And they may have an indwelling catheter. If they have an indwelling catheter, they need to do cath care, self-cath care. Because if the upper extremities are okay, you need to instruct them on cath care. You guys know that. Person has an injury C3, C4, and you come upon, you're taking care of a patient in the ED, and it's determined that that person has a C3, C4. Would you be thinking you'd be telling this person, would they be breathing? Generally not, because it's affected that area. they are a candidate for what?
Ventilation.
ET tube. If they haven't put it in root, they will need ET tube because you want to promote that area. And if you're turning these people, you log roll, which these guys demonstrated beautifully. Jamie, were you scared?
No.
Yeah. Okay. All right. We'll go on to neuro disorders.
I have a question. You said like she got in a car accident, but what if you're the only person like there? There's not
You
two
can't
people
log
that
roll.
live there.
You can't log roll.
But what you do when you get her out of the car, gasoline is going, so then you kind of like just keep
You
grab her.
raise them and then
You break
yeah,
it.
that way, that's
Correct.
what I'm saying. You're gonna take
You
it
get
from
the
front.
net, and you just kind of brace and goes in alignment. Okay, as you guys said, you want to, we'll spend the next 20 minutes talking about some of the peripheral nervous system disorders. This is myasthenia gravis. It is an autoimmune. It's autoimmune. That means it affects the immune system. And what you'll notice with this person is that there's a problem with the nerve innervation and musculature. So neuromuscular disease characterized by marked weakness, abnormal fatigue of voluntary muscles. That's all muscles in your body. Breathing, the intercostal muscles. For ambulation or anything, weakness of the musculature. So they get to go wheelchair bound, depending on the degree of injury. It's a defect in the transmission of nerve impulses at the myoneural junction. That's just saying nerve innervation to musculature. There's a misconnect in the signaling of the muscle to contract or just do what it's supposed to do. Causes include insufficient secretion of acetylcholine. Need to know it's not enough acetylcholine, which is a neurotransmitter. Or it could be excessive secretion of cholinesterase. How do you know the difference between these two? Acetylcholine excites, gets the muscles to work, contract. Cholinesterase kicks in and your muscle relaxes. So if you have too much of the cholinesterase, you'll have relaxing, but you then don't have the innervation to continue with the contraction. Yeah.
How is this different from Parkinson's? That sounds very similar.
Similar, different neurotransmitters.
Oh, because that's dopamine and
Yes.
acetylcholine, right? Okay.
Or it can be a response of the muscle fibers to your receptors. Your muscle receptor sites is not receiving that acetylcholine. Insufficient acetylcholine in neurotransmitter. The muscles don't receive that stimulus from acetylcholine at the receptor sites. Or it's too much of the cholinesterase. What you need to remember is insufficient acetylcholine. Okay, this is just showing what it's saying. Excessive cholinesterase, you notice that there's too much of it, so you're in that relaxed phase. This one is just showing another one where the receptors, you'll have that acetylcholine trying to go to the receptor, but it's blocked. This is just showing you. What you will notice with this person, or the physicians will suspect, myasthenia gravis. Remember, it's autoimmune. There may be some weakness and fatigue that's unexplained. They have difficulty chewing, which affects muscles. They have dysphagia. They have problems swallowing. So if they have several of these symptoms, something's going to come to mind. Classic to myasthenia gravis, and also MS when we talk about it, the first symptoms that occur are your vision problems, the ptosis and the diplopia. What's diplopia? double vision. What's ptosis? Droopy eye. Because you don't have that musculature necessary for the eye to open and close. They may even have a hoarse voice because the musculature needed to enunciate is not getting that stimulus, the acetylcholine. Heaven help it if they have difficulty breathing. It can be having increased shortness of breath that they've not had before. Or all of a sudden, it takes every effort to breathe, and it's not cardiac or respiratory involved. That's a culprit. Diminished breath sound because they're not breathing as deep. The intercostal muscles are not promoting the chest rise and fall. And some people, as diagnosed in the progression of the autoimmune degradation as where it's occurring, the person might have paralysis. So it's all musculature. All of those activities are using musculature. This is one person where they're beginning of the droopy eye. Which eye is beginning to droop?
Right.
This one here. Remember, it's an early sign, the vision problem. Okay, what do you want to do with this person? Monitor respiratory status and ability to cough, because a person needs to have a cough reflex. Okay? If they don't have a cough reflex, what are they high risk for?
Aspiration.
Aspiration, pneumonia. They can have aspiration and their pneumonia because they're not moving the irritant that is in the respiratory system. Okay. You want to monitor for respiratory failure. They're not breathing. They're not having the chest rise and fall. They're not getting oxygenated. You want to maintain, and this is when they're in the hospital, and if they're a candidate and they're at home and they've gone through some treatment, but they're taken care of by a caregiver, monitor suction and emergency equipment at bedside. In the hospital setting, it's going to be there. At home, if this person is long-term with this disorder, you have that at bedside. And you teach them. Monitor vital signs on this person. If this person, it affects all musculature, what would you think the heart rate would be?
Low.
They may end up with some bradycardia. And also, if they have that bradycardia and the heart is not filling as well, what do you think is going to happen to the perfusion of the rest of the body?
Good.
It's going to be decreased. Because that heart's not in that cardiac output. Monitor speech and swallowing abilities to prevent aspiration. What therapy would be the primary therapy that we use with this person to evaluate that?
Speech.
Speech therapy, because they do swallowing and speech. Okay, encourage the client to sit up when eating, because that helps gravity with mobility of the food. Okay. Assess muscle status. How can we do that? Grips and postures. What would you do to prevent atrophy of muscles? You said it earlier.
Range of motion.
Range of motion. You know, you're going to do your grips and pushes. You're going to do range of motion, so there's no atrophy, and the joints can maintain their range. Instruct the client to conserve strength and energy. So you want to space their care, cluster it. You don't want to tire them out. So you want to cluster the care, but do it in a way where it's spaced out. That's the activity that they did. If they're taking a walk, that's not the time to be walking 2 blocks. That's the time to space, start out walking maybe in their yard, around the perimeter of their home, and have that as they progress. Plan short activities that coincide with the times of maximum muscle strength. The time of maximum muscle strength is when they take their medicine. And we'll talk about the medication. Their medications are given early in the morning upon rising so that they can have that, the medications at a bloodstream level to promote them through the day. I'll say that again. The medications are given early in the morning, and they're given at that time to promote a blood level so that the person can maintain their ADLs throughout the day. We're not going to talk about the crises, but there is an anesthetic crisis and cholinergic crisis. But you kind of know what cholinergic. If you give something anti-cholinergic, what does it do?
It dries you up.
So cholinergic, they're going to be salivating, and they're going to be maybe some irritability, tearing, all of those things. And you want to administer anticholinesterase medications as prescribed. Basically what this slide is saying, the medications that they are ordered on, they need to take them for life. As long as they are myasthenic gravis, you know, they need to take those medications for life. It's autoimmune. Do they get better sometimes? Yes, but they need to keep those medications at a therapeutic blood level so that they can maintain their activities of daily living and plus breathe, period. Okay. You want the patient to avoid stress, infection, fatigue, over-the-counter medication. Stress can throw them into a crisis because even though you have the medication on board, stress can interfere with the therapeutic levels of that medication, where it diminishes the effects of the medications. So the person can go in crisis as though they don't have enough medication on board. Infection is a stress on the body. So here again, fatigue, where they're just tired out from too much activity, and taking medications that are over the counter that interact with that medication and decrease the effect. We're going to talk about some of the medications. The person should wear a medic alert bracelet and keep it on. Okay. They need to be availed of support groups, be it locally or statewide, them and their family, if the family is involved with their care. These are some of the medications. The anti-cholinesterase, they're working against the cholinesterase. These are people who, they may have some acetylcholine, but the cholinesterase, too much cholinesterase is being affected where that's one of the problems in the first place. You would need to give them the anti-cholinesterase med so that they have that uptake of acetylcholine and the muscle neural junction. Those medications are. You notice that they end with NON, mestinine, and this is NON, but ON, that's what I meant to tell you. Mestinine, tensilon. These are some of the other ones. Prostaglandin, which is one of the ones that don't begin in ON. Tensilon is a medication that can be given for maintenance to keep that blood level up, but it is also a diagnostic. And I'll tell you why. Diagnostically, to know if someone has myasthenia gravis, the physician will administer some tensilon. If the person improves in their musculature activity, they can breathe better, and they can have their limbs, move their limbs more readily. That's a positive tensilon test. They improve. So with that medication they improve, that means they have myasthenia gravis. If they improve in their musculature activity, they have myasthenia gravis. If the physician gives tensilon as a diagnostic tool, give an IV. If nothing happens, if they have a negative tensilon test, that means they don't. A negative tensilon test, that means they don't have MG or myasthenia gravis. If they have a positive myasthenia gravis, and then we'll go into the other 10. I'll have time to do the comprehensive stuff. What these people, side effects of these medications is sweating, salivation, nausea, diarrhea, abdominal cramps, and bradycardia, hypotension. What about anticholinesterase? There's increased salivation. They're sweating. They're losing fluid. They're nauseated. They're going to have some vomiting. They're losing fluid. Diarrhea. They're going to lose fluid. If they lose those fluids, what's going to happen to your blood pressure? Decrease. So they go into hypotension. And then they can have bradycardia also. The heart does not have enough volume. Okay. Things you need to do, have them administer the medication on time. Administer medication 30 minutes before meals so there's the absorption. And you could give them some milk and crackers to help so they can tolerate the irritation from the med. Monitoring core and muscle strength. The only way you're going to do that, you need to assess it. Grip pushes. Note that excessive doses can lead, anticholinesterase can lead to cholinergic crises. If you give too much, so if the patient takes too much of these medications, they can go into a cholinergic crisis. The thing that you want to give to this person is, remember it causes bradycardia, the antidote is atropine. I'll say it again. You know that they can go into bradycardia, the antidote for taking too much of your anticholinesterase, which can lead, if they take too much of them, they can go into cholinergic crisis. Remembering the symptoms of bradycardia, you want to give them atropine. And it's IV atropine. Myasthenic is, that's if the disease, the myasthenia gravis gets even worse. It's caused by rapid, unrecognized progression of the disease. Over time, the person, even though they have medication management, it may progress on despite medication management. This is they don't have enough acetylcholine. They're not taking their meds. Something's affecting the absorption of the meds that are needed to help them maintain daily needs. So we talked about that. Okay. You don't really need to concentrate on the crises, but if someone goes into bradycardia from taking too much of your cholinesterase, you will need to know, test purposes, atropine is the antidote. Okay. This is if they go into crisis, they don't have enough medication on board of the acetylcholine. You notice it's the same things that Dr. Newton followed. Difficulty speaking, aphasia, dyspnea because of the musculature and across the muscle, weakness, restlessness. You want to assess for these crises. And again, I tell you, just know your signs and symptoms of if someone has enough medication, they're not going to show these symptoms of your, like Mestinon and Tensilon. They're not going to show these symptoms because you're managing. If they get too much of it, too much of the medication, they can have crises also. I'm not going to mention on crises, you'll have to go wrong. Okay, that's just read up on cholinergic crisis. That's over-medicated with cholinesterase. And it shows some of the symptoms here, restlessness, and you're getting too much of it, there's going to be sweating, salivation. I'll go over this more on Tuesday. We'll have it over here. talked about the penicillin and the diagnostic. So if I had a negative penicillin test, do I have MG?
No.
We already know. Okay, we'll stop there. We'll start with